Hello everyone, my name is Dr. Aditya Gupta. I'm currently pursuing my DM in Pediatric Oncology from AIIMS New Delhi, having completed my undergraduation and post-graduation from the same institute. In this video, we'll be discussing about the oncology topic of the week, that is your chronic myeloid leukemia, especially from the NEET PG point of view. I wanted to emphasize on certain concepts that might not be clear, and so let's begin. I want you, every one of you who's watching this video, to imagine leukemia, acute leukemia, AML, myelodysplastic syndromes, and myeloproliferative neoplasm, like chronic myeloid leukemia, to be a part of a spectrum. They're essentially one or the other thing, a bit like that, a bit like that, a bit like that. What happens is, if we take inspiration from, epithelial cancers or carcinomas, what happens in the beginning? There will be the lining will become dysplastic. Fair enough. The cells will become of abnormal character. They will stop differentiating. As they move towards basement membrane, and when they penetrate the basement membrane, it will become carcinoma. Okay. This exact same concept is valid as far as your acute leukemias is also concerned. It's just that there is no basement membrane as far as blood is concerned. If the cells are dysplastic, they have impaired differentiation. That is what is known as myelodysplasia. Okay. But if this impaired differentiation cells, they are rapidly proliferating, and the number has typically increased beyond the 20% cutoff as far as WHO is concerned. The blasts are more than 20%. It is what is known as your acute leukemia. Acute leukemia has been defined as more than 20% blast in the bone marrow. That is your acute leukemia or acute myeloid leukemia. And myeloproliferative neoplasm is just something similar to that. It is increased drive. Your cells are proliferating at a very rapid pace, but they are not dysplastic. Sort of a hyperplasia-like picture. So what is essentially happening is, as far as AML, your acute myeloid leukemia is concerned, the cells are abnormal. They have impaired differentiation first. And at the same point of time, this impaired cell is proliferating at a very rapid pace. These two things together will cause acute myeloid leukemia or acute leukemia. If the cells are normal, the cells are not normal, they're just dysplastic, then it will be MDS. They are dysplastic, they're not normal cells, but they do not have acquired mutations as of now that they can proliferate. But it's only a matter of time that they will acquire those mutations because they're already dysplastic, and then they will also proliferate at a rapid pace of time. That's why MDS almost always transforms into AML after a certain point of time. What is myeloproliferative neoplasm? Myeloproliferative neoplasm is, there is no dysplasia. The cells are not normal. They're just proliferating rapidly because they have mutations in the tyrosine kinase that causes them to be constitutively active, and as a result, they're rapidly proliferating. It's sort of a hyperplasia with a proliferative drive, and this proliferative drive is because of the typical tyrosine kinase activation, which becomes inherently active. Now, specifically coming to chronic myeloid leukemia. Chronic myeloid leukemia, as you all know, occurs because of translocation 922. On chromosome 9, we have the gene for Abelson kinase, that is ABL. On chromosome 22, we have BCR, which is breakpoint chromosome region. These two things becomes together. When BCR comes in contact with Abelson kinase, this Abelson kinase is the tyrosine kinase. It becomes always active because of inherent dimerization with the help of BCR, and then it proliferates, causes proliferation of entire myeloid series of cells. Because of the proliferative drive given to RAS, JAK-STAT, and AKT. Okay, what happens is this translocation 922. It should be visible in the karyotype. Yes. So in order to diagnose CML, in 85% of the cases, this translocation will be present. But in 15% of the cases, this gene formation only will be present, and this translocation might not be visible in the karyotype or cytogenetics. In such a scenario, a more sensitive and a more specific, both sensitive and specific method is either an RT-PCR, which detects this gene, or a FISH, which detects this translocation, the specific translocation, which might not be visible on a normal karyotype. This has been asked in an entrance examination, which is the following is a more sensitive method for diagnosing CML. They will give you a clinical scenario of CML, ask which is the most sensitive method, and they will give you karyotyping or cytogenetics, and they will give you an example of RT-PCR. The answer would be RT-PCR because PCR will detect this gene, gene product of BCR-ABL, right? Now, what happens is, because BCR-ABL is there, this tyrosine kinase is inherently active. Like I told you, in myeloproliferative neoplasms, there is an increased drive of proliferation. The cells are not inherently dysplastic. The same what happened in CML is that these inherent drive will cause all the myeloid precursors to increase in number. So your neutrophils will increase, you will have neutrophilia. That's why your counts will be so high, more than 1 lakh, 2 lakh. Your basophils also will increase, your eosinophils also will increase, and most importantly, as compared to an acute leukemia where platelets are always low, platelets also will increase. Because platelets are also derived from myeloid precursors. In the very beginning, the hematopoietic stem cell divides into either a lymphoid progenitor or a myeloid progenitor. This myeloid progenitor then gives rise to erythroid precursors, neutrophil precursors, eosinophil precursors, basophil precursors, and platelet precursors. So all these series will increase. Your neutrophils will increase, your eosinophils will increase, your basophils will increase. That's why CML is considered an important cause of basophilia and eosinophilia, along with thrombocytosis. Right. So what will happen when you do a peripheral blood smear and when you do a CBC, your TLC would have increased, basophilia will be there, platelet will be there. Now you'd say hemoglobin also should have been increased. No. What happens is because of this hypercellular marrow, the erythroid precursors do not have enough space to proliferate. So hemoglobin tends to be slightly on the lower side. And CBC will typically reveal a TLC of more than 1 lakh. Platelet will be 6, 7, 8, 9 lakhs. Hemoglobin will be around 10. And on peripheral smear, all the series, all the myeloid precursors, be it metamyelocytes, myelocytes, promyelocytes, all will be there. The number of blasts will typically be less than 10%. See, the problem with CML is that it is essentially a sort of hyperplasia, but it's not exactly hyperplasia. Because of this inherent dimerization and this extreme drive, sooner or later the CML cells will acquire a mutation that will cause it to become dysplastic. And dysplasia plus this proliferative drive results in transformation into a acute leukemic crisis or a blast crisis. And that is what is typically happens with CML. CML has 3 phases. Chronic phases, when the blast is less than 10%. The patient will just have very non-specific symptoms, splenomegaly, TLC will be increased. That's about it. Sometimes they are incidentally detected that you got a PS done or you got a CBC done for some other random reason. कोई surgery होनी थी. You got a CBC done, TLC came out to be 1 lakh. Sooner or later, as they will acquire mutation, it will get converted into an accelerated phase and finally into a blast crisis. Okay, when the number of blasts will become finally more than 20%. And this is because of acquisition of further mutations that give it a dysplastic character as well. What are these mutations? They are given in your Robin, so can be asked trisomy 8, double Philadelphia chromosome or isochromosome 17q. The blast crisis can be a lymphoid blast crisis or a myeloid blast crisis. Now you'll ask, since it's chronic myeloid leukemia, why a lymphoid blast crisis? The fact that it's a lymphoid blast crisis shows that the actual mutation in the tyrosine kinase is present in a pluripotent hematopoietic stem cell, which is present before the myeloid and lymphoid differentiation occurs also. But most importantly, what happens is because of this drive, more importantly, the myeloid precursors are affected more as compared to the lymphoid precursors. The BCR-ABL fusion protein that is formed as far as this translocation 922 and BCR-ABL translocation is concerned is 210 kilodalton. That's why it's called P210, protein 210. Contrast it with ALL. Acute lymphoblastic leukemia also can have BCR-ABL and translocation 922. In such a scenario, the protein is of a smaller size but more proliferative drive. It is P190. That has a weight of 190 kilodalton. AML also can have this mutation. That time it is P230. So they can ask a very simple question that BCR-ABL is not present or translocation 922 is not present in which of the following? The answer would be in such a scenario something like CLL or some other malignancy they can give you. ALL, AML, CML. ALL, AML, CML. All 3 will have BCR-ABL or translocation 922. They can have this. CML definitely will have. ALL and AML also can have. But CLL, Burkitt's, they won't have 922. Now, what is the treatment? Treatment is simply the tyrosine kinase inhibitors. They have revolutionized the treatment. Imatinib is first generation, second generation is dasatinib or nilotinib. But remember, they do not cure since they are just curbing the proliferation. They are not essentially taking care of the initial mutation that has occurred. What is the clinical picture like I told you? Initially in the chronic phase, you will have just vague non-specific symptoms. एक type का hyperplasia ही तो हो रहा है. There is no dysplasia. So they will have increased TLC, they will have a massive splenomegaly, non-specific symptoms like fever, fatigue, sometimes no symptoms at all. It just gets picked up on a random CBC. I remember a child I saw in OPD once. I got a CBC done because the child was complaining of poor height gain. That was the actual complaint they came with. We got a normal profile done, CBC, thyroid profile, and we were thinking maybe we have to go for growth hormone testing and everything. When we saw the CBC, it had a 1 lakh count. On then did an examination. There was a spleen. It did not have massive splenomegaly, small spleen T, which was missed in the examination initially. But that's how CML can present. Very non-specific symptoms. You do a CBC, counts are very high. You realize, and PS will show myeloid precursors, and you will have a child who's in chronic phase of the CML. This is a very important thing that I want to tell you as compared to CML versus an acute leukemia. Acute leukemia, always and always platelet will be low. In CML, like I told you, since the myeloid precursors are increasing in number, myeloid precursors also give rise to the thrombocytes and the platelet precursors. So platelet will always be increasing initially as far as CML is concerned. Only when it transforms into a blast crisis, the platelet will decrease. Hopefully I was able to clear some of your concepts as far as what CML is, how it can present. Thank you and have a nice day.